From Redfield Medical Direction, I'm Lynn Nguyen, Associate Medical Director, and this is your April 2025 Protocol Review. Hey everyone, this is part 3 and the conclusion of our Pediatric Protocol Review for 2025. We'll start off with pediatric bradycardia, which varies depending on age. Generally, for infants under 2 years old, bradycardia is a heart rate below 100 beats per minute, less than 80 for toddlers and young children, less than 70 for school-age children, and less than 60 for adolescents. In pediatrics, bradycardia is often a sign of hypoxia or shock, which can result in altered mental status or poor perfusion. This is why a perfusion exam documenting capillary refill, skin turgor, and mucous membrane status are key in your assessment. Hypoxia is a common cause of bradycardia in pediatric cases, but you should expand your differential to include toxic ingestion, overdose, drug toxicity. In other words, tox, and more tox. Your approach to the bradycardic pediatric patient is simple, starting off with your ABCs. If bradycardia persists despite your supportive measures, there are several other interventions you can try depending on your suspected cause. If you're concerned for ingestion, treat the suspected toxidrome. You can refer back to last month's protocol review where we reviewed pediatric toxic ingestions. For cases of unstable bradycardia, you can give epi 1 to 10,000 every 3 to 5 minutes or try transcutaneous pacing. If you think the cause is increased vagal tone or first-degree heart block, you can give atropine 0.02 mg per kg IV or IO and repeat if needed. While trying these treatments, you should also be bracing yourself for an impending arrest. You can optimize your success with early oxygenation and ventilation. Now let's flip the script to pediatric tachycardia. In general, for infants less than 2 years, a heart rate greater than 160 is considered tachycardia. Between 2 and 12 years, it's anything greater than 140, and adolescents are similar to adults, with tachycardia defined as greater than 100 beats per minute. Starting with narrow complex tachycardias, you need to be able to differentiate between sinus tachycardia and SVT. Comparatively, sinus tachycardia is gradual onset and variable, and usually in the setting of an underlying condition like fever, dehydration, or simple anxiety. By treating the likely cause, you'll end up treating the tachycardia. On the other hand, SVT is sudden onset and notoriously consistent without variability in the rate. That can be as high as 220 in infants and around 180 in older kids. Depending on the kid's age, you can attempt vagal maneuvers. Chemically, you can try adenosine. If that doesn't work, or if the patient is unstable, you need to synchronize cardiovert. When it comes to Y-complex tachycardia, your biggest concern has to be ventricular tachycardia. As always, if there's any sign of instability, go straight to synchronized cardioversion. If not, you could consider adenosine if and only if you're confident that the rhythm is regular and monomorphic. We'll wrap up with everyone's worst nightmare, pediatric cardiac arrest. Like bradycardia, it's almost always secondary to something underlying: hypoxia, shock, trauma, or toxic ingestion. We have historically emphasized airway and breathing in children as it is the most common cause of pediatric arrest. Something as simple as early ventilation could help prevent a child decompensating into cardiac arrest. We won't be going through the PALS course during this review, but I will highlight some important points in our protocol. Remember that a bradycardia less than 60 beats a minute is the cutoff for starting chest compressions. Unlike our adult cardiac arrest protocol, you can give epi every 3 to 5 minutes. If you have a shockable rhythm, defibrillate at 2 joules per kilos, followed by 4 joules per kilos, increasing your energy until you hit either 10 joules per kilo or the adult dose, which is typically 200 joules. As a reminder, amiodarone dosing is 5 mg per kg, or a max single dose of 300 mg IV or IO, and this can be repeated for a cumulative total of 15 mg per kg. Alternatively, lidocaine is 1 mg per kg IV or IO. These cases are critically acute and relatively infrequent, so make sure you take the time to debrief after each case. Dr. Redfield and I, as your medical director team, are also available to go over these in any such cases, so don't hesitate to reach out. This was a Redfield Medical Direction production that was based off of protocols by Dr. Redfield and produced by me, Lynn Nguyen. Our theme music is from Infraction. That's all we have for this month. See you next time.